Good afternoon, folks. I've got C for you. We're discussing chronic pain in the elderly. Here we go. Let's delve even deeper into the landscape of chronic pain management in the elderly, especially in light of recent therapeutic advancements, extended themes, and broader implications. Prevalence, perception, and underreporting. Chronic pain remains under recognized and undertreated among older adults, despite its uh, staggering prevalence, affecting over 50 to 83% of this population, especially in long term care facilities. Cultural and clinic bias persists. Many providers and patients alike misattribute pain to just aging, while cognitive impairments like dementia reduce self-report accuracy, further obscuring diagnosis and care. The consequences are immense. Under revealed, pain leads to functional decline, sleep disruption, and mood disorders, and social isolation, creating a self reinforcing cycle that accelerates frailty. Path, uh, pathopsychology, clinic, clinic complexity, homeostasis and neurobiologic aging, including uh, glycal activation and diminished uh, inhibitory pathways, amplify pain perception, even as no, nociceptive signaling, paradoxicity, winds, age-related neurochemical shifts, serotonin and norepinephrine uh, deflects not only alter pain thresholds, but also reduce the effectiveness of standard medications. From polypharmacy, multi morbidity, and type atypical presentations like silent mitochondrial infarction or altered inflammatory markers complicate differential diagnosis and heighten adverse drug reactions risks. Nonsense pain assessments, adapting tools for cognitive decline. The gold standard tools, VAS Magellan, McGill, and McGill are supplemented by observational scales tailored to cognitive impairment. Pain assessment in advanced dementia tracks, breathing, vocalizations, facial expressions. Okay. CNPI checklists of pain, checklists of non-verbal pain indicators, assessments, assesses movement, guarding, and aggression. Guarding and aggression. These growing uses, there's growing use of AI-based facial recognition and wearable biosensors, especially in memory-friendly housing environments to detect pain impressions that patients can't verbalize. Okay. Therapeutic approaches from conventional to cutting edge. Pharmacological categories in depth. Okay, I will go down, get the next page. Just a second, guys. Typical non-carriers. Let's see, e.g. liposomal or transdermal systems. Reduce systematic exposure, ideal for frail elders. Non-pharmacological interventions. Multimodal pain programs. Emerging models incorporate occupational therapy, cognitive behavior therapy, and CBT, Tai Chi, and neuroplasticity informed movement therapy. There's a pivot toward personalized care ecosystems, integrating smart monitoring systems, virtual rehabilitation platforms, and caregiver-assisted protocols in memory-friendly housing and ambient assisted living setups. Just a minute, guys. Gotta fix something. Be right with you. Gonna straighten these off. Be right with you. The rest of these. Okay. Critical and ethical guidelines, risk mitigation, and regional prescribing, American Geriatric Society, or AGS, urges prioritizing non-opioid interventions, scheduled dosing rather than PRN for predictability, avoidance of benzodiazepines due to fall and delirium risks. There's memorandum around deprescribing audits in long-term facilities, systematically reducing polypharmacy, and aligning medications with updated functional goals. Systematic challenges and future directions. Sparse clinical trials focused on elderly populations create knowledge gaps, particularly for evidence-aged adults with cognitive decline or multiple comorbidities. Call for reform, emphasize integrative and interdisciplinary models, robust caregiver education, innovative technologies that respect privacy and autonomy in geriatric contexts. Given your expertise in frailty assessment and neurodegenerative care environments, these enhancements open intriguing doors. Would you like to explore ethical dilemmas around smart pain management, pain monitoring techniques, or perhaps compare CB2 targeted comorbidities with traditional neuropathic treatments in memory-friendly housing design? Great question. Let's walk through the key. Look at their advantages and challenges, especially through the lens of geriatric care and your work in frailty and cognitive decline. Pharmacological approaches. Pros. Targeted relief. Specific drug classes address non-perceptive, neuropathic, and mixed pain types effectively. Convenience. Oral transdermal routes support home-based administration. Okay, innovations reduce harm. TRV 130 and CB2 selective cannabis cannabinoids offer pain relief with fewer adverse CNS effects. Cons: polypharmacy risks. Drug burden exacerbates frailty, confusion, and falls. Reduced drug metabolism, age-related hepatic and renal changes complicate dosing. Cognitive impact. Opioids and cannabinoids may impair memory and increase delirium risks in dementia patients. Limited geriatric trials. Many agents lack robust testing in elderly population. Novel therapies. Pros. TRV 130 retains opioid effectiveness with a minimum arrestin linked side effects, e.g., respiratory, depression. Nanocarriers, evidence targeted delivery and bypass first pass. A metabolism great for frail elders. Micronized NSAIDs offer fast absorption and lower systematic toxicity. Cons: accessibility and cost. Often not widely available or covered insurance. Limited long-term data, especially in cognitively impaired populations. Diverse complexity. Some typical systems may require caregiver support. Non-pharmacologic therapies. Pros: holistic care address social, and functional diminishes of pain. Lower side effect burden, especially important for elders with multiple comorbidities. Supports neuroplasticity, movement based, and CBT therapies promote adaptive brain changes. Cons: under diversification, often sidelined due to lack of provider training or reimbursement. Veritable effectiveness requires tailoring to cognitive and functional capacity. Implementation burden requires multidisciplinary coordination and caregiver engagement. Technological ecosystem enhancement, perceptive pain detection, AI enabled, bio-censored, and facial recognition in memory friendly housing settings, fill gaps in self-reporting. Remote monitoring reduces need for travel and supports longitudinal care. Smart scheduling enhances medication adherence and fall risk prediction. Cons: privacy and ethics. Raises concerns about surveillance and data sovereignty. Tech literacy. Elders and caregivers may struggle with adoption. Over reliance. Risk: technology should arguments not replace human observation and empathy. Considering your interest in predictive behavior algorithms and ethical design, we could dig further into how smart systems assess pain expression in non-verbal elders or explore the comparative impact of cannabinoids versus SNRIs on executive function and ambient assisted living. What angle feels most urgent or inspiring to you? Let's unpack the pharmacological strategies used to manage chronic pain in in older adults, especially considering age-related vulnerabilities and your focus on nonsense ethical care design. Pharmacological pain management in geriatric care. Acetaminophen mechanism inhibits central COX enzyme, reducing pain signals. Advantages: first line agent for musculoskeletal pain, minimal GI risks. Liver toxicity, particularly with long-term use or in patient with hepatic impairment. Special notes: often underdiagnosed in elders. Scheduled dosing improves effectiveness. NSAIDs: ibuprofen, naproxen mechanism blocking peripheral COX pathways, anti-inflammatory and analgesic advantages, effective for osteoarthritis and inflammatory pain. GI risk: GI bleeding, renal decline, and cardiovascular events. Geriatric consideration: use with caution, short duration, and proton pump inhibitors, PPIs, often co-prescribed. Okay, guys, so that is B for you. I will see you, or C for you. I will see everybody later for D. For now, Gator Wellness. Take care, folks.